Yes, so a very good morning, boys and girls. Hope you all are doing well, right? So before I start the session, you know that today the sun will transit into Capricorn, that is Makara, and this marks the season or the arrival of the spring season, right? And this is a season which is full of festivals. You've got Lodi, you've got Bihu, you've got Sankrant, you've got Uttarayan, that is Sankranti, you've got Pongal. So amidst all these celebrations, let us also think that, this is also a mode of celebration, celebrating with your different subjects in the form of a marathon, which we are coming with you. So a happy festive season, and let's prepare, let's prepare ourselves for the upcoming exam, keeping this festive mood, keeping this celebration, because if you pass on this examination, it is actually a festival for you. Well, that is going to be a true festival for you, right? So enjoy that, keep that spirit, let it be very positive, and let's start up with revision series, which I'm going to start with physiology right in the morning. You know that physiology is the basis of all, it is the mother of medicine. So let's begin with physiology. So before that, bacho, let us just have a look over the vitals which are coming with an academy. We have got prepared and we've come up with the recorded sessions. All the recorded sessions are available to you, so you can subscribe. You can just look over to the prices. Okay, then the last sleep marathon which we are coming, that is between Jan 20 to Feb 25 subject wise. Then the NEET PG All India mock test, that is going to be held on 22nd of January 9 a.m. Right. Now, coming on and moving on to the first question of the day, which we think that these questions or these topics are really important for you. So, the first question which I have taken is from temperature regulation, right? Good morning, success, and I hope this much amount of success comes to you as you've kept your name in a positive mode of a success. Now, look at this graph. Just look onto the question before I ask you or before I give you the options. Which set of changes occur at point W compared with V? So this is the point V, this is a point W. You have to tell me what changes are going to take place. You can see that on the x-axis denoted is time in duration. On the y-axis we have got temperature, and we can see that over a period of time the temperature is rising. And what are you expecting when the temperature rises from 99 to 102 to 103? That means what changes are we expecting from V towards W? Options are, you have to choose between shivering, sweating, vasoconstriction and vasodilatation, right? So there are different options A, B, C, D, E. You will have to tell me what are you expecting: shivering, sweating, vasoconstriction or vasodilatation. Definitely I'll be explaining you. So from this point to this point, that is when the temperature rises from 99 to 102, what are we expecting in the change? So the correct answer over here, boys and girls, is E. What is E? E tells us that those changes are going to be shivering, yes, and vasoconstriction, yes, but there is no sweating and there is no vasodilatation. So what is this entire diagram or entire figure telling you about? This figure is telling you about the changes in the hypothalamic set point. For example, now suppose there is fever. Okay, you know that fever is going to be caused by infections, by various pyrogens, which are going to increase the level of interleukin 1, prostaglandins, which act on the hypothalamus and which raises the hypothalamic set point. So what do you understand by raising the hypothalamic set point? This means that the temperature of the hypothalamus has been raised. So the hypothalamus has become hot as compared to body. So what will happen? Suppose hypothalamus is now at 102 and the body is at 99. So the hypothalamus now assumes that the body has become cold And the hypothalamus is going to bring about those actions which will increase the body temperature, that is shivering and vasoconstriction, to prevent heat loss. So you have confused the hypothalamus, right? This is the confusion of the hypothalamus that is caused by the pyrogens, which raise the hypothalamic set point to a greater temperature than the body. And now, because the body temperature is less and the hypothalamic temperature is more, the temperature tries to correct it by exhibiting the responses like shivering and vasoconstriction. And there'll also be piloerection, there'll also be epinephrine secretion. All these are going to induce heat production. The rise in epinephrine is going to cause an immediate increase in cellular metabolism, that is also called as chemical thermogenesis. And one of the very important and the first thing that takes place is what is our cutaneous vasoconstriction, right? Cutaneous vasoconstriction, that is going to minimize the heat loss. So let's see this. So what we have done, we have raised the hypothalamic set point. So raising the hypothalamic set point means the temperature of the hypothalamus is more as compared to body. So hypothalamus tries to correct it by causing those features which are going to increase the heat production. That is vasoconstriction, piloerection, epinephrine, and shivering. These changes will then ultimately, increase the body temperature. This is the period of crisis. That means, that when you yourself get fever, what happens is first we get rigors and chills, and then there is lots of sweating. So if you take a tablet, or if there is a particular, a phase of fever that it will show spikes of getting up and getting down, what will happen is that it is going to then the hypothalamus is then going to reverse the condition by causing vasodilatation, and there is a sudden set of the hypothalamic set point. So a sudden rise in the hypothalamic set point and then a sudden reduction in the hypothalamic set point. This actually what occurs and results in the changes in this graph. So this is one of the very important temperature regulation graph that is related to hypothalamus. Remember, the temperature regulating center or the thermostat is hypothalamus, and in the hypothalamus it is the preoptic nucleus. Okay, the preoptic nucleus that is taking place, that is taking care of the temperature. You must also remember that the anterior hypothalamus responds to heat. It also has got osmoreceptors, so both of them, they go together, whereas the posterior hypothalamus is called as shivering center. Okay, it is called as a shivering center. So these are the important questions. And one of the another important function of preoptic nucleus is sleep induction, right? Sleep induction. So this is something which is important. And again, just one thing I would like to tell you, GnRH secretion is not by preoptic, it is by the arcuate nucleus. So this adding on, because hypothalamus itself is a very important set of MCQ. Now, let's move on to the next question. Suppose there is acute metabolic alkalosis. It is going to result in dash in the potassium secretion by the cortical collecting tubules, and that will result in dash in the plasma potassium concentration. So this is also one of the very important questions that is related to potassium with our renal physiology. So when there is acute metabolic alkalosis was going to take place with the potassium. So what will happen if there is alkalosis, and what will happen when there is acidosis? Okay? So यहाँ the correct answer is D before I tell you the explanation. Acute metabolic alkalosis is going to cause an increase in the potassium secretion by the cortical collecting ducts. That is going to result in decrease in the potassium concentration. Very good, success. So let's, give success a chocolate for giving the right answer. Okay, for giving the right answer. ठीक है. अभी देखो. Now, suppose there is acidosis. Okay, let us assume that there is acidosis. So what will happen when there is acidosis? the H plus ions, okay, the H plus ions, they get shifted into the cells because they are going to be buffered by the proteins. And when there is metabolic alkalosis, there is a shifting of the potassium from the ECF into the cells. Okay, this results in this including the renal tubular cells, and that contributes to increase in the potassium secretion and decrease in the plasma potassium concentration, that is hypokalemia. Good morning, Prince. Now remember that whatever amount of potassium we are taking in the diet, the reabsorption of potassium in the PCT remains constant. Okay, it is just around 60 to 65%. So if the potassium in the diet is less, or if the potassium in the diet is more, that handling is called as our distal tubular handling. Okay, that is called as our distal tubular handling. That is going to be done by your principal cells, which are present in the distal collecting ducts and in the distal convoluted tubule and the cortical collecting ducts. So the principal cells and the distal tubules, they are responsible for the handling of the potassium. That means how much potassium is to be reabsorbed or if the potassium is to be secreted. These principal cells, they are stimulated by the hormone aldosterone. You must remember that aldosterone has got an effect on the principal cells where it stimulates the activity of sodium potassium pump, and it also increases the sodium reabsorption by increasing the activity of amiloride sensitive sodium channels, which we also called as the ENaC channels, right? So distal tubules, yes, very good, Prince. And where are the drugs acting is again important question, clinical based question for you, right? So if you are anytime asked, the factors affecting the potassium secretion, remember it is going to depend upon also the rate of distal tubular flow. So if any times the rate of the distal tubular flow is increased, there is going to be increase in the potassium secretion also. Yes, good, Prince. Very good. So Prince has given wonderful answers. I think Prince needs to be appreciated by a chocolate. Next one. Which of the following is true of the tubular fluid that passes through the lumen of the early distal tubule, that is in the region of macula densa? Options: it is isotonic, it is hypotonic, it is hypertonic, it is hypertonic in antidiuresis, it is hypertonic when the filtration rate of its own nephron decreases to 50% below normal. So I'm asking you about the fluid which is going to come here. So suppose this is my nephron, PCT, loop of Henle. So your point, that means the early DCT, just where the thick ascending limb of loop of Henle is going to become the DCT, where you are saying that there is presence of macula densa, that means there is presence of the juxtaglomerular apparatus, that means DCT. So what is the correct answer? What is going to be the fluid tonicity over here? Anybody? Yes, Prince? Yes. So the correct answer is B. B, beta. The correct answer is B. That the fluid over here is always hypotonic. Now, whenever I take my class, I emphasize on this point very, very much, and so I'm going to do with you. Remember that here in the PCT, the fluid is always going to be isotonic. The reason is that kidney may the PCT reabsorbs equal amounts of salt, or you can say equal amounts of solutes and solvent. That is, there is isoosmotic reabsorption of solute and solvent. So the fluid in the PCT is always going to be isotonic. This is hard and fast. As this fluid comes over here in the descending limb of loop of Henle, we will see that the reabsorption of the water is more than the reabsorption of the solutes. Okay, because the thin descending limb of the loop of Henle is much more permeable to water as compared to solutes. So what will happen is that as it reabsorbs water, more amount of solutes will remain behind. So more amount of solutes remaining behind, the fluid in the descending limb of the loop of Henle is always going to be hypertonic. Right? It is always going to be hypertonic. Now, as this fluid ascends up in the thick ascending limb of the loop of Henle up till this early distal tubule. So this thick ascending limb of the loop of Henle and the early distal tubules, they are also called as the diluting segment. They are also called as the diluting segment. The reason is that these are the segments which reabsorb solutes. They pile up the solutes by a gradient of 2. So 200, 400, 600, and they keep on multiplying, right? They keep on multiplying, and that is what is contributing to, the countercurrent mechanism. Kunj Prajapati, Sasrikal. Thank you, and Sasrikal. Right? So they are responsible for diluting the fluid because they are going to take up all the solutes and they're going to pile it up in their remaining interstitium, surrounding interstitium, concentrating it. And the fluid over here always remains dilute, that is hypotonic. So remember, no matter whatever is your tonicity, this is always a hard feature, a hard and fast feature. Isotonic in the PCT, hypertonic in the descending limb of the loop of Henle, and hypotonic in the thick ascending limb of the loop of Henle up till the early distal tubule. This is never going to change. So this is hard and fast, irrespective of the presence of ADH. Because ADH acts over here, that is from the late DCT and the collecting ducts. From the late DCT and the collecting ducts. Another important question, Hamesha yaad rakho that maximum reabsorption of water is always in the PCT, even if ADH is present or ADH is absent. No matter how much the question is confusing, has got confounding, MCQ ka options, but remember that maximum reabsorption of water is in the PCT, right? So that's all for this question. Let's move on. Now, this is the image which is depicting the result of a cystometrogram that shows that the patient has got a normal control of maturation. Which phase of the cystometrogram would have been most altered in the case of an overactive bladder? Options are A, B, C, and D, right? So in the case of an overactive bladder. So before that, before I tell you the correct answer, let me tell you what is a cystometrogram. It is a relationship between the volume of the bladder and the intravesical pressure, wherein you take the pressure on the y-axis and the volume on the x-axis. This A is actually called as phase 1, right? Phase 1. It can also be written as phase 1A. This plateau is the phase 1B, and this is the point where there is onset of maturation is the phase 2. This question has been repeatedly also asked number of times in your NEET PG examination. So cystometrogram becomes a high yielding question. Here the correct answer is B. A person with a normal control of maturation. Point A represents empty bladder where the pressure is almost zero. A small increase in the volume causes the pressure to rise by 10 centimeter, but a further increase can accumulate 300 to 400 ml of urine without or a very little change in the pressure, right? This is based on the Laplace law. So this phase 1B is actually based on the Laplace law, which says that T is equal to P into R, where P is the tension, P is the distending pressure, and R is the radius. So how would you understand the Laplace law over here? Remember, when there is increase in the volume of the bladder, you are increasing the radius, right? So because of increase in the volume of the bladder, you are increasing the radius. So as the radius is increased, the bladder tries to prevent a rise in the pressure by bringing about a simultaneous rise in the tension. So rise in the radius is causing a rise in the tension, and that does not allow the pressure to increase. And because the pressure does not increase, you can see that there is a plateau, and the bladder is able to accommodate volume of urine without increase in the pressure. Okay, it is able to bring about an increase in the volume without a simultaneous increase in the pressure. That is what is the Laplace law, and this is because of the feature of the smooth muscle. That is, smooth muscles, they exhibit a very important property that is called as plasticity. So what is plasticity? This means that the smooth muscles, they do not show length tension relationship. Okay, they do not follow, there is no length tension relationship, and they follow the feature of plasticity. That means they are not following the length tension relationship. Yes, and after this, that 400 ml is the amount of urine that is going to start the maturation reflex. Next, which of the following is not a calcium binding protein? Options are calbindin, clathrin, troponin, or calmodulin. Yes, so here the correct answer is clathrin. Remember, clathrin is associated with your vesicular transport, right? It is associated with your vesicular transport, that is endocytosis and exocytosis. Calbindin is present in the intestine, where it binds to the calcium, and it is promoted by vitamin D. Calmodulin is the protein in the smooth muscles which binds to calcium and initiates muscle contraction. Troponin C, we know it is the feature of the striated muscles, that is the skeletal and the cardiac, right? Another important option is also remember what is caliquestrin. Caliquestrin is another calcium binding protein which is present exclusively in the skeletal muscles. If you happen to come across a word calcineurin, calcineurin is not directly a calcium binding protein, but it is a calcium calmodulin dependent protein phosphatase that activates the T cells of the immune system. And the calcineurin inhibitors are immunosuppressive drugs. Okay, so if you have to select one man out, uh, calcineurin can also be one of the option given to you. Next one. So the next question which I have taken is from hematology. Hematology, the clotting mechanisms are very important as far as physiology is concerned. So the questions, they repeatedly come on clotting and the tests which are performed, the factors which are present in the intrinsic and the extrinsic clotting mechanism. A patient is concerned about her gums that bleed when she brushes her teeth, and this is over a period of 3 weeks. She recalls digestive problems. She recalls that there is also episode of steatorrhea. She tries to ease herself by drinking herbal tea. The prothrombin time is 18 seconds. The partial thromboplastin time is 36. The platelet count is normal. What deficiency is there? Yes. Yes, Zainab has given the correct answer. Very good, Zainab. So the question is over here related to clotting, that is vitamin K, because you know vitamin K is involved in the factors second, 7, 9, and 10. Now, Prince, you are confused with vitamin C. That is also a good confusion. Whenever the vitamin C option would be there as correct one, this clotting time or the prothrombin time and the partial thromboplastin time would be kept normal. They are not involved or they are not affected if there is, deficiency or if there is vitamin C involved. So vitamin K acts as a cofactor for carboxylation reactions for the coagulation factors second, 7, 9, and 10. Yes, very good, Kunj. Normal values of the fat soluble vitamin are from the diet itself and from the bacteria. Now, vitamin K deficiency is going to result in impairment of hemostasis and the patient is going to come with bleeding gums, prolonged prothrombin, and partial thromboplastin time, the platelet count is definitely normal because there is no problem with the platelets. So whenever the patient is coming with bleeding, the problem can be either platelets, because platelets are one of the most important factor resulting in the immediate vasoconstriction by releasing serotonin and causing a temporary platelet plug. There could be increase in the capillary fragility. There could be vitamin C deficiency, vitamin K deficiency. These factors should be remembered. Also, I would like to tell you as an extra edge, please remember nicely the factors which are used in the intrinsic and extrinsic pathway and the specific tests which are done to detect the impairment of the intrinsic and the extrinsic pathways. This is very, very important. Yes, Kunj, mother's milk is not going to provide adequate vitamin K, and the intestinal flora of the newborn is also not developed, and therefore we happen to give vitamin K injections to the newborns. So, if you see the other vitamin deficiencies, they are not going to result in the prothrombin time and elevated partial thromboplastin time. And we know that night blindness is mainly with vitamin A, scurvy with vitamin C. So these are definitely not associated with this question. Yes, Rao, it is going to stay in the channel. You can look over it on the YouTube. It is going to be uploaded also. Now coming to another next important question. Inverse stretch reflex is mediated by muscle spindle, GTO, that is Golgi tendon organ, by your dorsal column pathway, or by your unmyelinated C fiber. So this is again a very, very important question that is related to CNS, and you will see that there are a number of questions which come on the stretch reflex and the inverse stretch reflex. Yes, anybody could come up with the correct answer first, and then I'll start teaching you about the inverse stretch reflex. So the correct answer is GTO, that is Golgi tendon organ. Now you must remember that we have got two important things to be considered. One is our muscle spindle and one is our GTO, that is Golgi tendon organ. Both of them are classified as mechanical proprioceptors, right? Mechanical proprioceptors. Muscle spindle is present parallel to the regular contractile muscle fibers, and muscle spindle is referred to as intrafusal muscle fiber. Whereas the Golgi tendon organ, it is present in the tendon and it is present in series. The innervations of the muscle spindle is 1A and type 2, that is primary and secondary nerve ending. That of the GTO is 1B. Muscle spindle detects muscle length, that is a stretch, or you can say the muscle length. This length which can be static as well as dynamic. Okay, static as well as dynamic. Whereas the GTO, that is the Golgi tendon organ, which is innervated by 1B, is detecting tension that is caused by overstretching. Tension that is caused by overstretching. Right? Now, the reflex which is caused by the muscle spindle is called as the stretch reflex, which is an example of a monosynaptic stretch reflex. Okay, it is an example of a monosynaptic stretch reflex. Whereas GTO is an example of a bisynaptic stretch reflex, right? It is an example of a bisynaptic stretch reflex. So this is a monosynaptic stretch reflex and a bisynaptic stretch reflex. And GTO reflex is protective to the body, protective in sense, that it is going to prevent the muscle from injury. So it is also called as a protective autologous protective stretch reflex, right? That is to be remembered. It is bringing about the relaxation of the same muscle. For example, you elicited the biceps reflex. It is going to bring about the relaxation of the biceps itself, right? monosynaptic and bisynaptic, and therefore it is also called as the inverse stretch reflex. So please be very, very clear. So see, suppose this is our regular contractile skeletal muscle, right? This is our regular contractile fibers of the skeletal muscle. That is, they have got the regular actin and myosin, and we call them as extrafusal. Very important thing that they are innervated by alpha motor neurons. Now, to differentiate them from the muscle spindle, this is the muscle spindle, which we called as intrafusal. Intrafusal, which is actually the stretch sensitive receptor, that is the muscle spindle, whose motor innervation is A gamma. So remember that this is a very, very important question and a very important topic for MCQ. Now, how much is the RMP? That is the resting membrane potential of rods. So we've immediately jumped on to photoreceptors. Okay. So when I say rods, I want to say that I've immediately jumped up to photoreceptors, that is the rods and cones. So what is the RMP of this rod and cone? Minus 70, minus 40, minus 12, or minus 65? Yes, anybody would like to come up with the answer? What is the resting membrane potential of rods? Yes, Aryan, Kunj, Rao, Prince. No, Prince. Minus 65 would be of the inner ear. Ear, right? Minus 12 is of your RBC. RBC. Very good. Zenab and Aryan has given the correct answer. It is going to be minus 40, and minus 70 is a hyperpolarizing RMP of the rods. Hyperpolarizing RMP of the rods. This occurs when light falls on the rod. So you know that we always say that action potentials are always depolarizing. One of the very, very important exception of a hyperpolarizing action potential is the rods. So what happens? So remember that at rest, this is the outer segment of the rod, and this is the inner segment of the rod. So at rest, the sodium keeps on moving and makes this inner aspect or of the rods less negative, that is minus 40 millivolts remains. It remains less negative, that is minus 40 millivolts. As light falls, now first of all, why this is I mean, why the sodium channels are open at rest? It is because of this GMP, the GMP which keeps the sodium channels open in dark and allows the sodium to come inside, and therefore the RMP remains less negative. Now, as light falls, rhodopsin, that is your visual pigment, will be broken up into series, and you will get this active metarhodopsin 2. There will be formation of batmorhodopsin, lumirhodopsin, metarhodopsin 1, metarhodopsin 2. So metarhodopsin 2 is the most active one. This is going to cause activation of a very important protein that is called as transducin. So this becomes an important MCQ. This transducin causes activation of the phosphodiesterases. It causes a decrease in the level of cyclic GMP. Decrease in the cyclic GMP level is responsible to cause the closure of the sodium channels. As the sodium channels close, they cause hyperpolarization, decrease in the release of the glutamate neurotransmitter. So the neurotransmitter which is involved over here is glutamate. And this is then going to result in the transmission of the action potential. So remember that in dark, the resting membrane potential of the rod is minus 40. As light falls, this is going to result in the activation of metarhodopsin 2 and transducin. That is going to cause closure of the sodium channels and hyperpolarization, that is minus 70. So this is an exclusively important part of your rods and cones. Moving on next. What is the cause of dicrotic notch? Now, the moment you hear the dicrotic notch, it should click into your mind that where are we getting this? When are we getting this? Which graph is going to show this? right? So what are the options? Passive filling of the ventricles, closure of the aortic valve, closure of the mitral valve, or isovolumetric contraction. So the correct answer is, anybody would like to give the answer? What would be the correct answer for this? Yes, the correct answer is B, that is closure of the aortic valve. So this is necrotic notch. Now this is the aortic pulse. Okay, so when we are recording the tracings and the pressure waves, this which we get, this is not JVP. Please be very, very clear. This is the normal pulse tracing. This is not JVP. Aryan, that what I told you, beta, that this is not JVP. JVP is the jugular venous pressure. That is the pressure of the right atrium. This is JVP nahi. This is the aortic normal pulse tracing. Is it clear, Aryan? Where this is the T wave, that is called as the tidal wave or the percussion wave. D is the dicrotic wave. This is the dicrotic notch. So this percussion wave, that is also called as the tidal wave. It is because of the ejection of the blood during ventricular systole. The dicrotic wave is because of the rebound of the blood against the closed aortic valve. And the dicrotic notch, which is also called as insusura, is actually because of the closure of the aortic valve. So this is a very important thing. Now suppose if I give you two pressures, suppose if I draw this and if I draw this, how will you tell me out of this A or B, which is the aortic pressure and which is the pressure of the ventricle? So remember this dicrotic notch, which is because of the closure of the aortic valve, where we are going to get the second heart sound S2. This is dicrotic notch or the dicrotic insusura, which is reflecting the aortic pressures. So this is all. Now next, moving on to the next question. A 43-year-old woman eats a meal which is having 70% of carbs, 20% of proteins, and near about 10% of fat. So this is just a clinical picture being given to you. We are not interested in the diet. 6 hours after consuming the diet. Now this is very, very important. 6 hours after the meal. This is the highlighting feature. 6 hours after the meal, there are intense peristaltic contractions that travel all the way from the stomach to the colon and over a period of 90 minutes. So again, important clue that is given to us is 90 minutes. Which of the following hormone is going to cause this? Wow. Kanduri CHC has come up with the correct answer. Very good. Yes, so the correct answer is the hormone motilin, because what we are speaking about over here, yes, Prince, yes, we are speaking over here about interdigestive movement, that is MMC, that is our migratory motor complexes. Very good. So remember that there are two movements. Suppose if it is a well-fed state, so well-fed state may we are going to get peristalsis. But if it is interdigestive period, especially we are given this 90 minutes, this is going to be caused, this is our MMC, that is migratory motor complexes. Peristalsis are brought about by your enteric nervous system, but this is brought about by the hormone motilin, right? These motilin, which is causing this MMC, they move at the rate of 5 centimeter per minute all the way from the stomach to the colon. They want to clear the GI tract and they want to make it available for the next week, next meal. They are also called as housekeeper waves. Okay, they are also called as housekeeper waves because they are cleaning the house, cleaning the GIT. And if they do not function, there can be accumulation of bacteria. Remember that also, that if they are not function, there can be accumulation of bacterial overload can be there. See, they keep the Bacterial growth limited. They are also called as housekeeping waves. Again, important MCQ. Now, let's move on next. A toxin from Vibrio cholera is likely to stimulate an increase in which of the following in the epithelial cells of the crypts of lubricant in the infected people. So I have seen that so many times the question is being asked on, I mean, the Vibrio cholera. You must also remember that it affects which intercellular junctions. It affects your tight junctions, which we also called as the zona occludens. This was also an MCQ. Right. Zainab, the correct answer is beta B, that is cyclic GMP. Right? Cyclic GMP. Yes, there is loss of electrolytes, right? There is loss of electrolytes. So cholera toxin, it causes an irreversible opening of chloride channels. Okay. Cholera toxin, it causes excuse me. Cholera toxin, yes, it causes an irreversible opening of the chloride channels in the enterocytes and located in the crypts of lubricant. Although the sodium ions, they enter the gut lumen to maintain electrical neutrality, the chloride ions into the gut lumen, the sodium ions, they move to the relatively large paracellular pathway. Yes. Yes, I'm just one second. Excuse me. Yes, yes, yes. Cyclic AMP. Yes, the correct answer is cyclic AMP. 1 minute, excuse. Yes, the correct answer is A, cyclic AMP. So I'm just pardon for this. Okay, yes, the correct answer is cyclic AMP. That is adenylate cyclase. Okay, adenylate cyclase. Now, another important question that was related to this itself, okay, another important question that was related to the ion channels itself is that which is irreversibly opened in the intestinal epithelial cells of the patients who are affected by cholera. Yes, it is cyclic AMP. I pardon or apologize, it is cyclic AMP. Okay, yes, anybody would like to come up with this answer? Yes, anybody would like to come up with this answer? So it is GM1, 1. It is 1. Zainab, it is 1. GM1. Right? Yes. Again, the correct answer is B, that is chloride. Okay, chloride. Yes. GMB, that is chloride. Now, another important same type of a question which I would like to tell you over here is that you are given options that which type of reabsorption is affected by the bacterial toxins that are causing diarrhea. So remember, they are bringing about, or they are mainly interfering with an electroneutral reabsorption of sodium chloride. Electroneutral reabsorption of sodium chloride. Right? Is it clear, everyone? Are you out of Prince? Yes, it is chloride. Zainab, chloride. Zainab, it is GM1. Are we all clear with the doubts? And we move on next. So the enterocytes, which are derived from the stem cells, which are located in the crypts of lubricant, they mature as they migrate upwards. Remember, they can be replaced in 3 to 4 days, and bacterial toxin is going to cause an irreversible opening of the chloride channels. Yes, very good. Now, adequate oxygen delivery at cellular level is present with which type of hypoxia? Now, this is very important. That means another way of asking this question is that which hypoxia does not stimulate the peripheral chemoreceptors, does not stimulate the peripheral chemoreceptors. So this is another way of asking the same question. What is the correct answer? Anybody would like to give up? Yes, no. The correct answer is Aryan. The correct answer is beta anemic. This is very, very important questions. All these three, they are going to stimulate the peripheral chemoreceptors, because here there is going to be a decrease in the delivery of oxygen, right? There's going to be a decrease in the delivery of oxygen, but it is only with anemic hypoxia. Okay, it is only with anemic hypoxia. What is the problem with anemic hypoxia? There is a decrease in the bounded form. Okay, there is a decrease in the bounded form, but the dissolved form of oxygen is normal. The dissolved oxygen is normal, and it is the dissolved oxygen that is responsible to create the partial pressure of oxygen. So the chemoreceptors, the peripheral chemoreceptors, that is the carotid and the aortic bodies, they are not deprived of oxygen, and therefore they do not suffer from hypoxia. Right, Prince, very good. It is also be seen in the carbon monoxide poisoning. Next one. Writing reflexes are mediated by. Now, when I say writing, I mean to say that these are the body correcting reflexes when an animal falls down. Cortex, pons, midbrain, medulla, or spinal cord. So what is the correct option? So come up fast with your right answer so that we can, in the limited time available, we can have more of the answers. Like I would give you an example, the GTO reflex and the muscle spindle, that is the stretch reflex. These have got integrating center spinal cord, right? So the writing reflexes have got integrating center midbrain. Okay, the writing reflexes have got integrating center midbrain. So there are various postural reflexes, and it is a very deep topic. I've got a separate YouTube lecture on postural reflexes. So remember, there are stretch reflexes. One of the very important is the positive supporting reaction, which is also called as a magnetic reaction that keeps the body erect, having center in the spinal cord. Then you have got crossed extensor reflexes, withdrawal reflexes. These reflexes have got integrating center spinal cord. They are stimulated by nociceptors, and crossed extensor reflex are associated with reverberating circuits. This is the feature, reverberating circuits. They have got a prolonged after discharge. That means they keep on discharging even after the stimulus. So this is important. Then you have got tonic neck reflex, labyrinthine reflex. These have got integrating center in the medulla. right? So this is important, stretch reflexes which you have. Then the body correcting reflexes, that means how does an animal corrects its body. But remember, these body writing reflexes with integrating center midbrain are more important in the quadrupeds, because in the human beings we are mainly using our visual inputs. So in human beings the optical writing reflexes are much more important. Okay, the optical writing reflexes are more important. Now, which of the following is true for hypoxic hypoxia? It is due to inadequate oxygen carrying capacity. It is due to slow circulation, due to inadequate gas exchange, or due to inability to utilize oxygen. Yes, so remember, inability to utilize oxygen is an example of our histotoxic hypoxia, which as an example is, suppose, cyanide poisoning. Slow circulation is what is our stagnant, that is our ischemic hypoxia. Inadequate oxygen carrying capacity is anemic hypoxia, and this inadequate gas exchange is actually hypoxic hypoxia, which is a very common example at high altitude, or an altered VQ ratio, obstructive disease. Very good, Aryan, Zainab and Prince. The correct answer is C. Very good. Next one. The oxygen hemoglobin dissociation curve is going to shift to the right in all the conditions except. So this is my normal sigmoid shape curve. This is going to be my right shift, and this is going to be my left shift. Right? So right shift is caused by hyperthermia, decreased pH, decreased H plus, increased carbon dioxide. So all of them are true except. You have to tell me except. So it is going to be caused by all except decrease H plus ions. Decrease H plus ions. Now remember, right means what? R. Right means more. What more? There should be more H plus, DPG, carbon dioxide and temperature. So these are the four factors which are going to cause the shifting of the right to the curve. Increase in the H plus will also be given as option in the form of acidosis or a decrease in pH. Right? Yes, Prince. आप क्वेश्चन तो पढ़ो बेटा. Hyperthermia will cause right shift. Increased carbon dioxide will cause right shift. Decreased pH will cause right shift. The question was asking except. Prince, the question was asking except. You did not read it correctly, beta. The question was asking except. Right? And remember that right shift is what is our Bohr effect. Which of the following does not affect the oxygen hemoglobin dissociation? Yeah, I got it. So just now we've understood that DPG, temperature, acidosis and carbon dioxide, these are the four factors that affect the oxygen hemoglobin dissociation curve. Rate of blood flow is not affecting the oxygen hemoglobin curve, right? Next one. What is the venous carbon dioxide level? Sometimes the question can be so simple and we can make it wrong. So the venous carbon dioxide level is 45, right? So remember, at the arterial end, the carbon dioxide is 40. On the venous end, the carbon dioxide is 45. Carbon dioxide is much more soluble than oxygen, and therefore just a 5 millimeter mercury difference, okay, just a 5 millimeter mercury difference can help the carbon dioxide transport. The carbon dioxide transport is depicted by the Haldane effect on the graph, Haldane effect on the graph, and the chloride shift, which is called as the Hamburger phenomenon. That is what is called as the chloride shift. Okay. So the Bohr effect was oxygen transport. Haldane effect is your carbon dioxide transport. Yes, very good, Adil. And remember that oxygen at the arterial end is 95, on the venous is 40. This much big difference is required for the oxygen movement. What are Purkinje fibers? They are nerve fibers, they are modified muscle fibers, they are retinal fibers, or they are modified connective tissue fibers. Yes, one of the very important, simple but a basic thing. Remember, they are modified muscle fibers which have been provided with a capability of rapid transmission because of large diameter fibers, right? Next, what is the reason for increase in the interstitial fluid? That means I'm speaking something that is related to edema or the collection of fluid in the interstitium. Yes, Aryan, correct. Increase hydrostatic pressure, increase oncotic pressure, decrease hydrostatic pressure, decrease oncotic pressure, increase hydrostatic pressure, decrease oncotic pressure. Very good. It is C. So these are called as our Starling forces. Remember, hydrostatic forces are pushing forces, whereas the colloid osmotic forces are pulling forces. So if you want to keep the fluid into the plasma or into the capillaries, the colloidal osmotic pressure should always be more than the hydrostatic pressure, and that colloidal osmotic pressure is primarily and majorly brought about by albumin, right? Next one. SA node. So when I say SAN, I mean to say SA node. It is innervated by nucleus ambiguous, nucleus tractus solitarius, dorsal motor nucleus of the vagus, or the Bodzinger complex. So remember, the best answer is nucleus ambiguous. Nucleus ambiguous and the dorsal motor nucleus of vagus, both of them are concerned with vagus only. But dorsal motor is more towards GIT and nucleus ambiguous is more towards CVS. Okay, that is heart. Another important thing, the vasomotor center, that is your pressor depressor area. All these centers, they're going to get inputs from which center? From the nucleus tractus solitarius. So the nucleus tractus solitarius, it is going to modulate the activity of the vasomotor center and the cardiac vagal center. During sleep, which hormone is increased? Serotonin, GABA, acetylcholine, or dopamine? So the best answer is GABA. So you can see over here that when there is increase in GABA, okay, when there is increase in GABA and when there is decrease in histamine, there is going to be a decrease in the activation of the thalamus and cortex and resulting in our NREM, that is our true physiological sleep, which is characterized by no dreams. The dreams are not consolidated. Decrease in GABA, increase in histamine. It causes increased activation of the cortex and waking up, right? Whereas acetylcholine and increase is responsible for your REM sleep. REM sleep is characterized by consolidation of dreams, or the dreams are registered, right? So the last MCQ, iron transport from the enterocyte is by DMT, that is divalent metal transporter 1, 2, is it ferroprotein or it is GLUT1? So we know it is DMT, that is divalent metal transporter 1, which is present on the apical side, which will transport the absorbed iron. On the basolateral side, you will have hephacetin and the ferroportin, which are going to transport it on the basal side. Iron transport is again a very, very important MCQ. I hope, boys and girls, today's session was interesting for you, helpful to you. Only one thing which was just a mistake of the not of the mind but of the tongue, that cyclic AMP for cholera toxin. So we meet more and more. I just give you my warm wishes, my best wishes for your upcoming exams. I just want that be very stable, be very calm, because it is just the last moment where if we lose our patience or if we lose our confidence, we can just have a fall, right? So the last moments are such that we have to be very, very calm and patient, just keeping a confidence over our previous knowledge. Remember, day prior to exam, I must sleep well, eat well, I must pray, I must be very calm, and I must have confidence, self confidence, self faith, self motivation, because the best person who can motivate you is, look at the mirror, it is you itself. So just look at the mirror, Find yourself smiling and you will get motivated. So that is all from my side for the day. Lots of love, happy day, happy spring, and lots of festive season to you. Thank you and take care.